So sadly, Joanne Locke is in the operating theater still. So the talk of him is not here present, and so the first part was thought to introduce generally the guidelines out now in the famous British Journal of Surgery. And I will show you this guideline so directly and go a little bit through it, but we will jump then more directly in the usage in daily practice, and especially the topic of this webinar is the LiMAx, of course, how to use with patients undergoing liver surgery or in hepatology. So wait a moment, I will join this guideline with you. You probably have seen it already. No, this is a wrong one. Sorry, I have to go back.
It's okay. Mm-hmm.
This is the webinar. Do you see it? The paper? Or was it the wrong one?
The press release.
Exactly.
This is what we see is a press release,
yeah.
Martin. Yeah. So
this was
that's
ours.
also
So
nice,
that was a wrong window. Wait a moment.
Yeah.
Now you see the correct. So this is the paper we are talking about today. It's the E-AHPBA ESSO ESSR Innsbruck consensus guideline. So a big name, but it was a long process. I can talk. I can tell you where a large number of European international experts were in process going through all present literature for this topic of preoperative liver function assessment before hepatectomy. That's exactly the question addressed by this guideline. And of course, not an easy question because very
Het kantelpuntje voorbij, maar daarna goed.
Het licht even gezien en daarna...
Sorry, there was some noise in between. I go forward. And all these experts worked on the literature and did a Delphi process out of the literature with validations. You see it in the paper coming to questions. And all these questions which are addressed in the paper and addressed for the single topics and all I can say methods you can use in evaluation before hepatectomy were then in this Delphi process voted for, and only messages and questions with a vote about over 85% of all experts. So there were more than 40 experts in this process were in the guideline, and it was addressed here also and created an algorithm. So there are a lot of algorithms. There are also for the LiMAx, and LiMAx algorithm published 2010 in HPB. I show some excerpts later on in my talk, and this algorithm addresses, of course, in principle general evaluation of the patient in the beginning with general lab values, of course, which gives you some clue probably what's going on with the patient and what you can do with the patient. And of course, then you have some decision if there are abnormal findings for function, for some things, or large resections. And this is exactly what then is important that you do not get after the hepatectomy postoperative post-hepatectomy liver failure, because this is dangerous and might be with very high risk in special situations. So you should avoid this, and you will not have to have this that a patient dies by liver insufficiency after resection, of course. And all this is it about. In this Delphi process, so I go further on through this paper very fast. All these questions: do you need blood values? What can you do with biopsies or other things like sarcopenia is not useful, of course. But then very interesting, of course, the functional imaging. Imaging at all is, of course, important, that you plan in critical cases or major resections, that you plan you with volumetry, you plan your resection in detail if it's a critical resection, and of course then use function with ICG or LiMAx. In the end, these are the only two tests which can help you with judging the patient and judging the risk in the end. So this is what I in brief will tell you about the guideline in directly out of the paper. As said, sadly, Johan Locke wanted to go more specifically through it, but I directly will start now with my talk, and there I will come back to this guideline in the end. But in the beginning, I want to introduce the LiMAx test. You can see the presentation, hopefully now. Yeah. If not, please give me a sign, but I think it works. So we talk now about how it works. And this is my disclosure, of course. And the LiMAx et al. Is a very special test, and it's a metabolic test. And I want to introduce, who is not very familiar with this, in the beginning in 3 slides, how it works exactly and what is the special thing with this, and which makes the test working so good and so exactly. Because it's a metabolic test, and it's a test where you do an IV application. This avoids every transport problems and every resorption problems by the bowel, and you get directly high concentration at the liver over the artery and the portal vein in the end. And this is very important, that you get a high substrate concentration in the liver. That's done by IV bolus application of a special substrate. It's 13C-metacetine. That's very not harmful and a very good substance, because it has itself nearly, and it's shown broadly over many years, really no side effects. That's very important. And the 13C group is important because you later on generate, by metabolizing this 13C-metacetine, 13CO2, which is exhaled by the lung. So, and we measure then this by continuous breath analysis. We measure then this 13CO2 in the breath, and this is what is used for calculation of the metabolic capacity. And it's not like the ICG, for example. It's not a clearance test, and it's not a test analyzing clearance, but it's a test analyzing really the metabolic product generated by the liver hepatocyte. And that's very important because you really see with this test what is the liver doing, what is the liver metabolizing in the moment of the test. And this makes it so precise and makes it directly that you can judge in the moment of the test what are the hepatocytes really can do, and what is the capacity of metabolizing the substrate, which is general metabolized by general the CYP1A2 cytochrome, which is very conserved and not influenced by any other substrates or inhibited or induced, not very much. And by the online kinetic analysis, you get in the end by a very special technique which exactly can differentiate normal 12 to CO2. So 12C is the normal non-radioactive carbon in all the whole environment, and 13C is also a non-radioactive isotope which is present in 1% in the normal environment, but enriched here, of course, for the substrate. And with this special technique, I don't want to get into details, you can directly live and continuously differentiate and measure the quantity of the 12CO2 and 13CO2. So that is how it works. And all this together, of course, and with some calculations and standardizations by body weight, you can get an inter-individual comparable value of the hepatic metabolization capacity of one individual person. And this is the LiMAx, is a kinetic metabolic value in the end with microgram per kilogram an hour. So that gives you this kinetic value. And how can we now assess the resectability in liver surgery? Of course, by planning, good planning and evaluation of the patient. Of course, the general conditions for operations are important, no doubt. Oncological concept is very important. Everybody knows this, of course. You need interdisciplinary tumor conferences and workups to get the concept in place. And of course, you have a technical resectability in the liver given by the vessels, by all bile ducts, and so on. And you need to get, of course, in R0 resection, this should be possible to get a good outcome of the patient. But fourth is the functional resectability. Sufficient postoperative liver function is the important point to focus on. Not the liver function before an operation, but the postoperative liver function is important. It has to be calculated. This is very really important clue in all this. And with the residual liver volume and the parenchyma and the liver function, you can calculate this. This is a very nice study, quite old already, but of course a large number here, and analyzed the multivariate factors for mortality after liver resection, after hepatectomy. And of course, it's blood loss, number of segments resected, preoperative bilirubin, complex hepatectomy, platelet count before age. All this is important, but influenced by some parameters. But all these first 6 parameters give you, or 5 parameters, give you an influence on the postoperative liver function, how the patient is coming out. And you need to measure in the end this. And we have shown this in this original publication in Annals of Surgery 2009 with all factors which are described in literature analyzed, and the only factor in the multivariate analysis for mortality and liver failure was the postoperative liver function measured with the LiMAx on postoperative day 1, and you should not go under certain cutoffs I will show you later. And this is also the case for hepatocellular carcinoma patients, and resection in these very important indication also because you often do not know how good is the remnant function or the function overall, and these cirrhotics very often, or if they are not cirrhotics, it's of course better for the resection if it's a large or major resection, but the functional liver, the future liver remnant function is a multivariate important factor you see here in this paper. And of course, you can differentiate between the stages of fibrosis in histology by the LiMAx, by the function. I do not go further in detail here because probably Guido Gerken will say something to that, but this is also, of course, very good that you can measure this and draw your conclusions from this and compared to other tests like API or transient elastography or so, the cutoffs and ROCs for these stages are quite good and partly better than the other tests. So coming back to the prevention of the postoperative liver failure, and this is most important before the operation, because we want to know before the operation what is the risk and how can I reduce the risk and optimize all steps before I go to the operating theater. And the assessment of the future remnant liver function is the most important thing for that. And you need the LiMAx test, the metabolic capacity to judge the parenchyma, and the CT or MRI volumetry. And with this, you can calculate the future remnant liver function, as shown here in real-life patients with a good correlation in this calculation compared to the real measurement afterwards. And from all this data, we developed, as said already, 2010, the LiMAx algorithm, and this is based on the analysis of the risk of hepatic injury. So this is a very broad definition, because if you have any risk of hepatic injury, and that might be only adipositas and steatosis of the liver, this is enough to say here yes, or further former chemotherapy before, because of the colorectal carcinoma and later metachronic liver metastasis. So in all these cases, you have to be say yes, and then do a LiMAx to see where you stand, if you have a normal liver function or reduced liver function or very worse liver function, where you better should not do any surgery. And on the other hand, if you have really no risk and no injury, really young patient, no fatty liver and so on, you can directly go to the resection of one segment, two segments, no problem, and do not need any further tests. But if you have then reduced liver function, or you plan a major resection of more than 4 segments, then you should go more in detail. And in these cases, you need a volume function analysis using exactly what I said, the volumetry together with the analysis of the metabolic function, and by this you can calculate the future remnant liver function. And this is very important, because if you see this data of this HPB paper 2010, you have these classes of remnant functions, calculated remnant functions after resection. And if you then look to the mortality rates, if you have a good and sufficient remnant function, over 150 is the cutoff here. You have 0 mortality, and also in the group of 100 to 150, it's very low. But below this remnant function, below 100, it's increasing mortality up to nearly 40% in patients with a remnant liver function below 80 micrograms per kilogram an hour in the LiMAx. And this is a group you do not want to have, and you can plan alternative resections. You can plan some improvements by portal vein embolization, for example, before you go to resection. And this is what gives you the really the patient the a good feeling for the risk and a good outcome in the end. That's the important thing. And you can also calculate this. We have some simple worksheets on my scientific website, vftl.eu, and there you can get real results sheets with the calculation of the remnant liver function by entering all these parameters. That's very easy and free for download. We have analyzed at the Charité in earlier times also a big analysis of all patients, no selection, no dropouts, or no patients taken out of this analysis of all resections of one or more segments in the years 2006 to 2011. And we introduced in between here in the year 2008 and 2009 in this area, the LiMAx algorithm as shown in our workup, and it was very consequently introduced. And you see here these larger numbers at the Charité in at these times. And interesting, we had during time more cirrhosis because we did more resections in cirrhosis because we know what we can do and that the risk is low if we do the right resection. More complex hepatic resections, that means also Klatskin's, yeah. Here 29%, then 37 or 43%. And on the same at the same time, we had lower rates of post-hepatic liver failure and lower liver failure-related deaths. This was very low compared to former times, and this is really a very interesting result, I think, from real life. So one case, for example, here, 65 years in emergency, abdominal pain and low HB, and in the HCC in segment 7 and 8, in cirrhosis 10 centimeters, so no other therapy options, and some blood here in the abdomen, yeah, and the LiMAx of this patient was normal, was good with 434. So we did an anatomic right hemihepatectomy in this emergency situation. And you see here the specimen of this large HCC. Luckily, the bleeding was only from some adhesions to the phrenic muscles and not from the tumor itself. So this is now already 5 years ago, and the patient is still alive with a good postoperative LiMAx and discharge at these former times, 12 days after this operation. So you can do things like this. You probably in other circumstances and without measuring really the function would not do it, or you in the end do not know what you do and where you end up. Yeah. For the LiMAx in this workup before liver resection is present one randomized clinical trial. This was also the trial for EMA registration of the 13C metacetine. And this is very important because it was done in 6 academic liver surgery centers, and patients were analyzed by LiMAx postoperatively, and if the remnant liver function was good and about over 150 micrograms per hour and kilogram, the patient was directly transferred back to the normal ward bed because he has low risk, as we see mortality nearly zero. If, of course, any cardiac risk were ruled out before by inclusion. And what came out by this study is that by working up the patient with the LiMAx, the overall complication rate by Clavien-Dindo classification here over grade or similar grade 3A was significantly lower, and this is in the end level 1 plus evidence that using the LiMAx in this setup is really beneficial for the patient. And of course, these studies shown were also in the ESSO, in this consensus guidelines. And I have taken out here 2 sentences from which was here in the Delphi process also by all experts consented. And it's written that that's an important point. The strengths of LiMAx include its high reproducibility and lack of relevant risks to patients. So this is very important. The methodology is so consistent that everybody can do it, and you get everywhere and by everybody the same result on the same patient. That's very important, of course, because this is not given with every other method, and many methods are not controlled exactly by the method and how it is worked up. So, and for all clinical questions in here, the median level of evidence range between 2- and 2+, and only, as you see here, and this is the study I showed you already, only for the LiMAx, we have the level 1+ evidence. So this one randomized controlled trial. On the world, there is no other randomized controlled trial for any other method present. That must be really mentioned in this circumstance, that really it's of course difficult to do real and controlled randomized controlled trials, but in the end it's the highest evidence, and this gives really data which are strong. So and this resulted in the end that, and that's also only available for LiMAx, that the whole test and the 13C metacetine is authorized by the EMA in certain countries already and clearly registered there. That's also only given for this LiMAx test. So I'm through this very fast and clearly, I hope. Postoperative liver failure and related deaths can be predicted by direct postoperative LiMAx with definite cutoff values, as you have seen, and we can prevent it by measuring and calculating, of course, this by algorithms, and especially the LiMAx algorithm before hepatectomy. and can improve the outcome. And it's recommended by this new guideline clearly and registered in Europe, and it's the only test which is registered here. So thank you for your attention. And now, of course, we are open for questions. Please.
Hello, it's Guido speaking. Can I ask a question?
Yes.
Yeah, of course.
Okay.
Guido.
Martin, congratulations for these excellent results and this excellent talk on the results. And I think this is tremendous progress in liver surgery during the last 10 years. And however, I think there's a lot of things to do. So far, it is a very, very positive progress in the selection process for patients for liver resection. And from my point of view, I think you should test everybody, every candidate who has a risk of liver disease. Every patient who has who undergoes liver resection or liver operation should be tested by the LiMAx, because we see so many advances. This first point. The second point is that using the LiMAx, you can give more patients a chance to get operated, because you test the patients before and to see whether there are candidates with a so-called good liver function test, and so you can do it without to lower the risk in those patients. And therefore, I think it's in advance for those patients which have to go operation.
Yeah, thank you for your summary. And that's exactly the case I showed you, because it was so impressive at these times, because we were under pressure, a bleeding patient, in the abdomen, from probably or maybe HCC in the liver. So what to do? Go directly to a not so easy for the patient operation. Of course, surgically it's not so difficult to do a hepatectomy, right? But can he make it afterwards? And this test in this situation clearly gave us the judgment to do it, and it was a perfect result, of course.
Here's a question. Sorry, here's a question from the audience in the chat from Jackson to Martin. Do you think the LiMAx is also necessary for the ablation surgery method?
Yeah, this is a good question. In fact, there are a few papers already out for this topic. And of course, ablation can be very different. You can do a small ablation and a larger one, and also the method might be important of ablation, if it's internal radiotherapy or LFR or microwave ablation. But if you plan a quite large ablation and there's a relevant or known liver disease or cirrhosis, you probably should do it in advance, because you get more security of the outcome and can better judge the risk for the patient, clearly.
Okay.
Do you have other questions, Ralf?
No, from the audience, I don't have any at this point in time. But maybe after the talk of Guido, this will change. So
Okay, yeah. Then we will hand over and introduce. Introduced he was already by Urife to Professor Guido Gerken, who is a famous hepatologist and of course in the area of using the LiMAx in the hepatology area is very experienced, and we are glad to have him here. Guido.
Okay, thank you very much, dear all, for the introduction, and I'm very proud that I can take place in this very, very exciting occasion. I think we, as I told before, I think it is very, very important progress in patients with liver disease to handle them before and after operation. And so the most prominent result is that those patients can be better treated before operation, better observed. And we have heard about this from Martin, these results. And however, we have not only patients during or before operation, but the most of our patients are independent from the question of operation. They are patients with hepatological disease, and now I will focus on results on LiMAx in the field of those patients in clinical diagnosis. And during the last 10 years, I could perform more than 1,500 to 2,000 tests in LiMAx in our patients in the center in Essen and also in the center, Helios Center in Felbert. And so I can say, I give you some insight in those patients. Next, please. So the liver at all, I think, is the very most prominent and very important organ in the whole body. It's important not only for the metabolic homeostasis we have talked about to measure it, but it is also very important in the production of nutrients like carbohydrates, fats, proteins, vitamins. It's very important. The synthesis, for example, for coagulation factors is important for the distribution of products during the body and to do it out of the liver, to it in the body, and also for the storage of very important things during the process in the body. Next slide. So liver diseases are major healthcare problems, and I think more than 1 to 200 to 2 billion people suffers from liver disease in the world around, and 2 million of those are die from acute and chronic liver disease each year, and this is an important healthcare problem worldwide. And a third of our liver patients develop end-stage liver disease and also hepatocellular carcinoma as the worst case scenario in those patients with liver cirrhosis are now the second or third leading cause of death from cancer worldwide. So we have in the Western world also combined more than 200 million people suffering from chronic hepatopathia due to non-viral liver disease and the so-called NASH. And these patients are rising more and more and coming to a risk in liver disease #1 all over the world. And 50% of those patients advanced fibrosis and even liver cirrhosis. So also the very big coming and rising problems during the next 10 and 15 years. So taken together, cirrhosis will be the most common non-neoplastic cause of liver disease, at all, in Europe and in America among GI tract diseases. Taken together, also a major healthcare problem. Next slide. So what can we do in the diagnostic procedures all over the people? And we have a lot of batteries for the diagnostic of a liver patient. for example, biochemical laboratory analysis. And why is this important? Because liver disease are diseases which are long-lasting over a long time, maybe 20, 30 years is the ongoing process. From acute liver disease, maybe some are going fulminant, the others are going chronic, and they're going on within 10 or 20 years to liver cirrhosis as the end stage of liver disease. And finally, then we have the complications of liver disease. And HCC is the most prominent worst case scenario in those patients with advanced liver cirrhosis. And in our clinics, we see more and more those patients with advanced cirrhosis, viral or non-viral etiology, and developing HCC, especially in combination with metabolic disease, so-called these combinations of maybe a viral disease with a metabolic disease or toxic disease with a metabolic disease, that makes higher the risk of developing HCC. And our task is to get known to those patients as early as possible, and we only can higher the outcome of those patients only if they treat them in an early compensated status. And therefore, LiMAx will help to stratify and to differentiate those patients. So in biochemical tests, we have patients doing fibro test or steatosis test or NASH test. They're the most indirect tests in biochemical feelings, and they are not very exact, and they are not very broadened all over the world so far. The most second important diagnostic tools are structural, functional tools like imaging with sonography, with endosonography, with computed tomography, or in nowadays with FibroScan. Yeah? That means the analysis of fibrosis is an everyday task which we have to do in our patients, and this has also changed our mindings in the last 10 years concerning the diagnostic approach. So if we go on, next slide, we can then create a future algorithm for liver disease. We have heard from Martin something like this in the studies, beginning with the clinical findings, going on with the easy laboratory analysis and the so-called routine imaging with sonography or with CT or MRI. And then we have those patients undergoing immunological, viral, or genetic markers. We cannot do it in every patient. We have to do it in patients with special diseases, those to lower the cost, and then to think about what is the best markers to go on with. And finally, we have also liver histology. In those cases where we have not yet analyzed and not yet diagnosed the disease itself. And histology is also a very fantastic tool. We can do immune cytology, we can now do liquid biopsy, we can do with NGS molecular probes, and therefore we have a lot of batteries in this field, but only this is in some patients where they need to do that. Otherwise the costs are too high. And now next is that we can integrate in this process of the algorithm, we can integrate the new tasks and the new tools with elastography, that means FibroScan, and LiMAx. In this time schedule, at this position, we have to do this indirect and direct measurements of structural and functional liver disease. And therefore, you can say that this has to do before we do cost rising tools like immunology, genetics, or viral or histology processes. Next slide. And why we do liver diagnosis at all? Liver diagnostics are in the laboratory analysis based on special enzymes with the transaminase levels in the site of the liver cells, cytoplasm, We have then cholestatic parameters, which are easily to determine with alkaline phosphatase, bilirubin, or gamma GT levels. And we have the so-called synthesis factors of the coagulation with 2, 4, 7, or 10, which we can determine. And we have choline esterases. It's also very interesting point of diagnostic, which shows us a little bit the function of the liver cells, but it does not always correlate very good with liver function, and so therefore it is only a screening and not at all a realistic marker of liver function. This is too unspecific. And next slide, please. And however, the transaminases are the basic of the liver diseases, and those liver diseases are not only a cosmetic determinants, but they represent an increasing mortality. If we have elevated liver enzymes 2 times, we have 20% more risk of death. If we have elevated liver enzymes more than 5 or 10 times, we have more than 5 or 10 times higher death risk. And this is coming from real large popular studies during the last years, and therefore I think it is important to begin with these enzymes in a lot of cases, also in prevention. And in Germany, we have now a new possibility to determine transaminases in preventional medicine with the program of 35 plus. And in those patients which are older than 35, we can, in each patient, we can determine transaminases level to screen for liver disease. And this is very important concerning the outcome of liver disease, and therefore we should moderate, and we should talk about those screening programs with 34 program in the general patients all over, which is financed by the statutory health assurance. Next slide. Yes, it's important. Next slide. So, taken together what Martin was already talking about, what are, next please, what are the markers for the liver function? Next please. Yes, so we have during the last 50 years a lot of different assays developed. This is the so-called Child-Pugh score, which everybody knows from the beginning of the students, medical students. We are doing this since more than 50 years. We have other tests like FIP4 score, which is integrated in all the studies now, indirect system for the measurement of liver fibrosis. 20 years ago, when I started already in Essen with Christoph Bolsch, we performed all over in studies the MEGIX and the ICG functional tests, and we did studies on this, and we could show that they were not reproducible very good in those patients undergoing liver-related liver transplantation. And therefore we were asking for newer tests, and then came the LiMAx. This was the approach which put us in a new area, and now we have the LiMAx, and therefore we are very happy to have it in these last years, and now we can go on with the real-time liver function test. Next, please. Next, please. So the LiMAx we talked about, I will skip this. We have done it with Martin, but I will show you some practical results from the daily workup in our clinic and in our outpatients practice. This is a patient, female, 68 years old, which I followed for more than 10 years, and she suffered from HCV cirrhosis in earlier days, and she was also treated, but did not respond very well to the medication so far. So 6 years ago, or 5 years ago, in 2018, this patient had a LiMAx assay from 5 0.05 microgram per hour per kilogram. So it was a very good and normal function. At that time, we compared it to the transaminases. They were normal. To the bilirubin, it's normal. It was an advanced fibroscan, fibrosis stage 2 or 3, correlating to the liver cirrhosis. We had a MELD score of 13 and FIB4 score of 3.19. So this was not very impressive, and we were happy that this patient had a very good liver function. But we could see, if you analyze the phases of the liver assay, of the LiMAx assay, we have two phases. The initial phase, I call it the first round of Formula One, when the race is going on, and we saw the rise of the process of the metabolization of CO2, and here there is an edge in this curve. It's not normal, and so the patients get up to normal data, but a little bit later than the normal curve. So this was the first hint that this patient suffered from a liver disease. 2 years later, the same patient came back, and we saw the liver function has diminished. We have normal transaminases, normal bilirubin. We have FibroScan going on, but we have MELD score a little bit elevated to 16, but FIB4 score was not yet very elevated. So this was an indifferent status. We couldn't say what is going on in this patient, and the only test which showed that the liver cirrhosis is progressing to a bad condition was the LiMAx test. And even 2 years later, now, some months ago, we saw that the diminishing and the failure of the liver insufficiency is going on. Now he has diminished to 178, and at that time, no rise in transaminases, no rise in bilirubin, no further rise in MELD score. The only rise was in the indirect FIB4 score. So taken together, only LiMAx was showing the reality of the functional liver disease and the functional capacity and the insufficiency of the ongoing liver process. Only with LiMAx test we were able to monitor it and to show it and to talk and to see what we can do for the patient now. So next, please. This is another patient, a young girl on the other side, a young girl now, 20 years old, girl with autoimmune liver disease, autoimmune hepatitis. She came to our clinic with acute liver failure. So transaminases levels of 1,750 and with a bilirubin of 11 FibroScan. And you see this was a very advanced, worst case of the acute process, and this could be shown by the LiMAx. It was diminished to 196, and as you can see here, we have no real rise in the LiMAx in the initial phase, and he didn't get to the maximum, no more than 195, as a very, very bad condition and liver insufficiency. Next please. And then we did treatment. Please, the next, please. The next, please. Yes, we did treatment with steroid. Go back. Yes, we did a steroid treatment, and as you can see here with steroids, we were able to normalize the liver function very, very quickly, within days. It normalized to 526 within days after the steroid in this autoimmune disease. The transaminases levels are going down to 100, bilirubin are going from 11 to 2, and the FibroScan was still the same. So in that case, only LiMAx was able to show that these patients did not need acute liver transplantation in this status, and it was we were able to treat them conservatively with a steroid treatment, and so we were happy that we could avoid liver transplantation in this case too early. and is going on with the normalization. Some weeks later, the LiMAx assay was normalized to 746, and at that time, the transaminases was they were normal, bilirubin nearly normal, and the FibroScan now went down to 5.8. So the liver recovered, really recovering of the liver, monitored with the LiMAx very, very intensively. Thank you. Next, please. Next slide. Yes, this is another very interesting case. It's a colleague, 62 years old, female. She's practicing, still practicing, since more than 20, 30 years in own practice. And this patient suffered from autoimmune liver cirrhosis, autoimmune process of the liver. And now, 6 years ago, in 2018, the patients had a very, very bad LiMAx with 260 due to the fact that at this point the patient suffered from portal vein thrombosis and developed ascites. So the clinical function was bad. The MELD score was 9, not very impressive, but the LiMAx itself was very, very diminished to 260. And then we treated it with anticoagulation, and the vessels opened again, and so some time later, 5 months later, the liver function was getting better and better to 329. The MELD score was the same, and then some months later, he held a good function, but the MELD score was also the same. So the differentiation of the different phases of the liver disease was only monitored by LiMAx assay very, very carefully and dynamic and realistic. And then the disease story went on in 22. This patient suffered from COVID infection, acute respiratory disease, and you can see here how the LiMAx is going down. So this supports the fact that COVID is also going into the liver and also making the liver in a bad liver function. And this was at that time for us very, very impressive. And so he recovered from COVID, but he did not recover from the liver function because this patient developed at that time, some months later, an erysipeal, an infection, maybe as following after the COVID infection, again a respiratory insufficiency, a respiratory disease, not corona-based, and he had a lot of family stress in the field, so he couldn't better the liver function at that time. Now, actually, she has recovered, and she has now 393. So this is very excellent in the follow-up. At the same time, MELD points are 11. So we cannot, if you see the MELDs 9, 10, 9, 10, you cannot differentiate how is the realistic function of this patient. He is in an end-stage liver disease, okay. But we can see that the liver function is dependent from the the comorbidities the patient is developing. So this is for the monitoring of those patients, very important. Next slide, please. And the last case, which is also maybe impressive from my point of view, this is also a colleague, 33 years old. He came to me for a screening of liver tumors or liver alterations, unspecific, and he was overweighted. He had the body weight, body mass index of 33 at that time, and I called him to change lifestyle and to change the food and to make more sports, and because at that time he was diminished liver function is 295. 294. And the curve is still in a normal range, but the maximum capacity of the liver was diminished. And after the change, within 3 months, after changing lifestyle, after optimizing body weight, after changing the food, he goes down to BMI of 29. He lost 20 kilograms. And what is going on with the liver function? He normalized. He normalized within 3 months to 435. And I think this is also a very, very interesting point to show how good the recovering of the liver is during the follow-up if the treatment is very efficient. And therefore, we are very happy to monitor this by the LiMAx. Next, please. And taken together, as we have discussed it with Martin still, we see that the LiMAx data are differing and correlating to the status of the liver. Those patients with no liver disease have normal assays. Those patients with a chronic asymptomatic liver disease have still a good function, and those with compensated cirrhosis are going down with the LiMAx to 264 in this study, and those with decompensated cirrhosis go down further to 150. So this correlates very clearly, shows very clearly the correlation between the status of the liver disease and the liver function monitored by LiMAx assay. Next, please. Another correlation, as we heard about, is the correlation of LiMAx with different other biochemical and functional scores, with MELD score, with FIB4 score, with APRI score, with liver spleen, and all taken together, all these different non-invasive tests, the LiMAx assay is the best one to differentiate between the different groups of liver disease. So this is an advantage to do also LiMAx in those patients to monitor very, very carefully the different stage of the liver disease in the long time running up. Next, please. And this also shows the rocks under the curve, that the LiMAx assay is still the best one during these different non-invasive tools. So taken together, the LiMAx is an advantage in determining exactly liver function during the follow-up in patients with advancing liver disease. This can be monitored very carefully. Next, please. And also with liver histology, we have a good correlation. We have done in 100 of patients correlation between the LiMAx values and between the histology status called according to the Desmond classification, and this correlates very well. The better the histology, the better the LiMAx is going down, and we have clear data showing the correlation between LiMAx test and histology. Next, please. And the predictive value also shows, next slide please, that in the long running of 90 days mortality, the LiMAx test is the best non-invasive test in showing the liver function. So taken together, to conclude, LiMAx test is a liver-specific assay, the only one which is very intelligent approach with the LiMAx procedure, and shows a linear correlation with the current liver function. Next, please. And this test provides additional findings in different indications that I've shown you from individual patients and from groups of patients with acute and chronic liver disease, with before and after liver surgery, before and after therapy monitoring, maybe with TIPS or with ablation, or with chemotherapy, or with drug-induced liver disease. I could also show a lot of cases with drug-induced liver disease where we can monitor and treat the patient very, very earlier than we have done it without. Next, please. It is a universally applicable test. He is metabolic. He is functional. and he is dynamic and bedside. And next, please. And this is very, very helpful in the progression in the diagnosis of liver disease. We can better make treatment decisions. Next, please. And we also can, next, please, better assess the prognosis. How we can do the procedure with LiMAx now. I have shown you in the beginning the algorithm. Now I've shown you when we have to do really in liver diseases the tool of LiMAx. We begin with the clinical and biochemical evaluation, and then next we perform transelastography. And if you have a normal transelastogram or nearly normal, low 10, then we have no cirrhosis, and we don't need any further test if we do this workup. But if we have done transelastography and we have more than 40 kilopascal fibrosis, advanced fibrosis, then we have cirrhosis. Clearly, we can say this is only in according to cirrhosis, and we don't need further investigation to say that this is clinically a liver cirrhosis. But in between more than 10 and less than 40, it is unsure what we have. Do we have advanced fibrosis? Do we have early cirrhosis? Nobody knows, but it's important to make decisions on the patient's treatment and the patient's workup. And in that cases, I think it's very worth to perform the LiMAx assay. And we have a LiMAx assay then in that cases with more than 235, we have no cirrhosis in those patients, but if we have less than 245 in those patients, we can say that we will have cirrhosis, liver cirrhosis. And this is done with a high sensitivity, with a high specificity, and I don't know any other test which can show this sensitivity and specificity in the characterization of patients with or without liver cirrhosis. So let me conclude. Next, please. From our opinion of how thousands of patients and maybe hundreds of studies, we can say that LiMAx test is for us a very intelligent screening test for the global quantitative dynamic liver function. There is no other test worldwide who is showing that. We have a quantitative function test, and this is good in times where we change from to evidence-based medicine, from eminence-based medicine to evidence-based medicine. We need data, and therefore it is worth to have a quantitative liver function test like LiMAx. You can convince the patients much more with data than with opinion, and therefore it is helpful also to discuss these things with the patient itself. The liver-specific selective liver function marker is LiMAx in the diagnostic therapeutic algorithm. In all cases, maybe acute, maybe chronic, maybe cirrhosis, maybe toxic, maybe carcinogenic. And the LiMAx can also help in monitoring patients with different other methods of liver function, of direct and indirect liver function, and they can help to stratify and to differentiate and to make a good review of prognosis of the disease. LiMAx test can help to manage patients with hepatotoxic drugs like chemotherapy, where we are doing really in the workup with our tumor clinic, that we monitor those patients with chemotherapy in cancer, maybe in different situations after liver transplantation, for example, in the long term for running up where they have immunosuppression and so on. And they were difficult patients, and therefore we can help to stratify those patients and to make a better dosage of the chemotherapy at all. Also in ablative treatment like TACE and SIRT. We also have a good assessment. We have talked about a lot with Martin Stockmann's presentation, pre and post-operative situation. This is excellent data, fantastic data. And the consensus conference, the European Consensus Conference, has shown that a lot of liver surgeons are now convinced from the value of the assay. And we also can use it in critical ill patients, far away from operation and so on, in those patients on the intensive care unit. Yeah? There we can monitor patients with sepsis. We can monitor patients with multiple organ failure. We can monitor patients with heart failure or thoracic surgeries in other than liver surgeries, and also is an advance in those patients to make a better prognosis of the patient itself on the intensive care unit. And I think this is also very progressive advances, important progress in the new medicine. So, taken together, next slide, please. If we can summarize, we have not only good medical data, but we also have a cost-benefit analysis confirming the economic efficiency of the LiMAx. This is a mini health technology assessment which has been done some years ago in Austria. And this has clearly shown that LiMAx, the performing of LiMAx is an economic procedure. And it can help you in the clinical workup of patients with in-house staging or with the long-term running of those patients. And it can be recommended for application in everyday clinical routine, as shown our data from conservative chronic liver disease. And also finally, everybody is showing, is asking whether we can diminish the costs in our patients. And we can say that the LiMAx costs are not yet covered in the statutory general health insurances in Germany, but it can be integrated in those patients which are in-house, and we can diminish costs of those patients in-house when we are doing this in those patients with statutory health insurance. But the costs are covered directly and really by private health insurance companies. You can argue very good with lowering the cost, with bettering the efficiency of treatments, and then the healthcare insurance are so intelligent to cover those costs. I have no problems with that if I talk about these facts with themselves directly. So indeed, for me, it is a tremendous advance in the overall medical progress we have in liver disease. Next, please. And my wishes is now that we have to have a consensus on it. We have the consensus that we go into a new era of liver function with LiMAx, in a better era with evidence-based data, and not yet evidence-based, but evidence-based. Evidence-based is better, and therefore this test is for the liver. For example, also like a nephrologist who is doing GFR, or for a hepatologist, or for a cardiologist who is doing BNP. So we have to do for liver function the LiMAx test as the best non-invasive and non-toxic assay, as a quantitative and real-time functional assay. We have a lot of critical data on it, which are published in peer-reviewed journals, not more than 50, but more than 250 publications so far, I think so. And we have also a very attractive business model and documented health economic benefits, which can be shown by the health technology assessment and by the discussions with the private insurance companies. Last slide, finally, last slide. So LiMAx is saving life. This is helping to save lives in the postoperative situation. It reduced the liver failure up to 45%. It is also helping us in the diminishing of the postoperative mortality, which is to 63.8% reduced. This is published in different journals. So it is an advance for those patients pre and post operation, but also in those patients before any discussion operations to make better the life and the disease management of those patients. Finally, at the end of this year, my wish for the future, maybe a little bit more general outlook, is that we have to take into account that every patient should be vaccinated with liver diseases, HPV, HIV, and maybe now also with COVID. Seen that COVID can make disease of the liver. They have the wish for the future is to make better the lifestyle, to normal the body weight, to help that patients can do more sports every day and every week. We have taken into account that we have to tell to our patients not to smoke. Smoking is no decision in any patients. We should advise our patient not to take alcohol. Every liver patient should be asked not to drink, because alcohol is advancing the liver disease, and alcohol is a bad drug for the liver and should not be used in those patients. But we have positive effects like coffee. Coffee is good for the liver. We know it now from different retrospective trials so far that coffee can pathogenetically lower fibrosis. And we lower fibrosis, we lower cirrhosis, and we lower cirrhosis, we lower cancer. So coffee is indeed a very positive fact in our patients. Yes, we can do it, really. And finally, we have to take into account that we like to have for our patients a very good prognostic liver and lifestyle, and we would recommend that this will be for the next years one of our aims, to diagnose patients earlier, to make them more efficient treatments overall, and to help indeed to lower the global problem of liver disease. Thank you very much.
Yes, thank you, Guido. Jaken, this was really a great talk and a great run through all these hepatology topics. Maybe I may start with one question regarding the tips. There are a few data available already, 2 tips, and tips might be harmful if the patient is already too worse in his function and status. What can you say to this?
Yeah, thank you very much. Excellent question. We have some data on it. We have published some data on it in our group, and we can now clearly differentiate what patients are able to be tipsed or not. So if we do LiMAx before tips, we have liver function diminished to less than 150. I think I would not recommend to do tips in those patients. The liver function is too bad. And after tips, we see a down regulation of the liver function very tremendously, and more than 50% the liver function and the perfusion of the liver is down regulated after tips. So it is very, very difficult to tips patients with less than 150. They go down to 80 maybe, and yes, we have shown that 80 is the very critical date of liver function. And I have seldom seen patients going out of the hospital if they have such a bad liver function. Then they have to be maybe we can help with transplantation. And but upper than 150, I have no problems to do TIPS. And this is also good for those candidates which we have with bilirubin of 3 or 4, where we say, okay, from the data, we should not TIPS patients with more than bilirubin of 3. But I think it is better to look for the function, not for the date of bilirubin. Bilirubin can be the result maybe of hemolysis. It is not representing liver function. And therefore we have more better indication to do TIPS and to do LiMAx in those patients before TIPS, and then to be independent from indirect diagnosis of higher bilirubin or age, for example. We have earlier we have discussed that patients more than age of 60 should not be TIPS. I think we have TIPS patients with more than 70. And if we have a good LiMAx test, we can do it. If there's a good cardiac function, we can do it.
Yeah, very interesting. Thank you. I think this is very important, and this is also an indication where you can judge the patient in the actual situation and draw really clear clinical decisions for or against an intervention. Yeah. Okay. Are there other questions? So we have a few minutes left to answer questions. Please, you can also switch your mic on and your camera on and directly ask us. That's really welcome. Now's a chance. Jan Bednarz, yeah. Go on.
I actually don't have a question, Martin. As far as you know, I was your PhD student in Berlin, and my dissertation was about LiMAx. So I pretty know the topic from a user perspective. I can say that I've used this test. Maybe there are some people here around who don't use it regularly. I use the test regularly for liver surgery questions. Actually, I work here in Essen, formerly in Aachen. Both are very large hepatobiliary centers conducting a lot of liver surgery. In Aachen, we used it on a regular basis. In Essen, we are now implementing it. I have pretty good experience with it. It's easy to use. It gives valid results, and I would be interested actually in the new technological setup which you have, because there are a lot of LiMAx machines out there. I think I don't have the newest version actually, but maybe Ralph can say something about the new generation of LiMAx tests, how long it takes, how easy it is to use, how easy it is to transport around the hospital. That would be actually for me very interesting, because you and Guido Gerken held a great speech about the theoretical basis of it, but from a consumer perspective, this is also very relevant.
Yeah, thank you for your clinical feedback out of directly out of the clinics. That's very important also, and of course, like technology, devices are getting smaller and smaller, and this is a good development. Of course, maybe the Ralph Kohnen or someone of the company can say something to this.
Yeah, sure. Thank you.
Results are the same. That's important. And that's very important and are consistent.
Of course, the technology inside is still the same, but actually, what is very impressive is that the device, also Jan, is the one which has a weight of which is really a big machine. Let's say 130 kilograms on big rolls. Now the device is like a laser printer. So it's 9 kilograms, and it comes with a cart, and can easily transport it in the clinic, can be transported to the ICU if you have a question there. and also the connectivity, let's say, to the device is very easy from both sides. So there is an improvement from the technology side, but on the other hand side, the technology itself, so the infrared lasers and everything, it's still the same, right? So and it needs to be the same because all the studies have been done with this technology, right? So yeah, that's
But
basically.
Is this new device already out for sale?
Yes.
Ah, okay.
Yes.
That's very
Okay.
nice. Then maybe we will be happy to see it here in Essen as soon as possible.
Yeah.
Other questions, please.
Wait a second.
Do we have something in the chat?
Yes,
Yeah.
patient that you are now in Essen. Yeah? I think we have a good chance to support this center in Essen by doing liver function more and more. And since we have data and we have experiences with liver function in Essen, yes. And I think it supports also what I've said, that it is a real-time assay. You can do it everywhere in the clinic. You can do it in the intensive care. You can do it in the normal ward. You can do it in an ambulance. And it is bedside. And so it's no reason not to do it. Yeah? You have no reason to. You can do it. You can do it with your bicycle. You can do it in the hand and go with a bicycle to the next patient, to the next ward. So it's excellent to perform it in every patient.
Okay, here's one question. Actually, do you think LiMAx would be added in the cirrhosis application related consensus guideline? I think that's a question for Guido, isn't it?
Yes, I think we have now a lot of publications, yeah? More than 100 publications. I think Ralph can support it or not, but I think there are more than 150 publications already with the LiMAx in peer-reviewed journals. So the time to integrate it in the update of the diagnostic procedures in cirrhosis is there. I think so. Yeah.
Yeah.
In fact, there are already some smaller guidelines for HCC, for example, where already in these guidelines LiMAx is mentioned, but of course there are still, as ever in new technologies, randomized controlled trials may be at some certain time points necessary to have more evidence, but it's already mentioned in a couple of guidelines. Okay. If there are not any more questions, I hand over to Ralph for some final words. And
thank you very much, Martin. So thank you all. Thank you, the faculty. Thank you, Martin. Thank you, Guido, for the excellent presentations and the questions that have been asked from the audience. And hopefully, actually, also this webinar will help to let's say, have this LiMAx also in other countries, not only in Germany, Austria, and Switzerland, and of course UK, but of course I think the test is worth to be more present also in other European, Asian, and probably also in the United States. Yeah, thank you very much, and thank you for listening. We will put the record of this webinar onto our website so that you, if you want to look at it at a later point in time again, you can do that. All right. Then have a nice evening.
Thank you all.
And
Bye.
having a good rest of the week. All right. Bye-bye for now.